Hi, I'm Dr. Andrea Zimmer. I'm the director of the Oncology Infectious Diseases program at the University of Nebraska. It's my pleasure to talk to you today about vaccines for cancer survivors, the who, what, where, when, and why. Some disclosures: I have institutional research funding from Astellas and Anson, and I will be discussing COVID-19 vaccines, which are currently authorized via the Emergency Use Authorization Program. Here are some of the objectives of my talk today. So why do we vaccinate? So vaccines are some very important interventions that we have to protect both individuals and the community as a whole against infection. So they help reduce the individual's risk of getting a specific type of infection. They decrease rates of infections among a community. There have even been instances where we've been able to eradicate infections altogether from specific countries, specific regions. And so there's been multiple success stories with vaccination programs. There is the concept of that you've probably heard a lot lately about herd immunity, and it basically refers to the ability of a community that's vaccinated or has immunity as a whole, where it reduces the rates of spread among a community, that it offers protection to immunocompromised patients and others that either cannot get vaccinated or will not be able to respond to vaccines to protect them from those types of infections as well. And even if it doesn't completely prevent infections that are targeted by the vaccines, often it will reduce the severity or other complications induced by these infections. There also is usually a cost benefit to vaccination. So we see reduced hospitalization, reduced healthcare costs, reduced loss of work as a result of these infections because they're less severe, less duration, and less people need to seek healthcare as a result of these illnesses. So there's many benefits to vaccine. It's a very easy and great intervention to protect populations, especially immunocompromised populations, from specific infections. I wanted to point out some very helpful resources that you can refer to at later dates to get information about vaccines and vaccine preventable illnesses. So one of my favorite sites to go to is the CDC. They actually have a lot of information about illnesses that can be prevented by vaccines. They have some great charts on recommended vaccines for children and adults, and at what age and what indications patients should receive specific types of vaccines. The National Foundation for Infectious Diseases also has some great charts and resources. That's where this chart here on the right came from. The American Cancer Society has some great information on vaccines and infections specific to cancer patients and their survivors. And then also the National Comprehensive Cancer Network, or the NCCN, has a lot of great information both for patients and clinicians that provides a lot of guidance documents for clinicians and patients as to treatment and prevention in specific cancer populations. So these are some really great resources that have a lot of data-driven evidence and recommendations. So here are some charts that I refer to on a regular basis, basically obtained from the CDC. So this is the recommended regular adult immunization schedule. This chart is updated yearly, so this is the 2021 schedule. And this is for routine vaccination in all adults based on age groups. And so everyone's recommended to receive a yearly influenza vaccine. There's discussion about the tetanus, diphtheria, pertussis vaccine, the MMR vaccine, if depending on the age of birth, the varicella vaccine for specific age groups, and then the HPV and other vaccines for specific indications. And then they have different color coding, and then they have discussions or paragraphs that discuss what indications these other vaccines have. And then on table 2, there's another chart that goes through immunization schedules for specific groups of patients and breaks it down by, for example, pregnancy, diabetes, liver disease, healthcare workers. And there's a category for immunocompromised patients, which is where I would include cancer patients and cancer survivors. And so this group here that's highlighted in blue are the category or the subheading that I'm going to focus in on. Specifically going to go over influenza vaccine, the tetanus, diphtheria, and pertussis vaccine, as well as HPV, pneumococcus vaccine or strep pneumonia vaccine, as well as COVID-19 vaccine, which is unfortunately not on this chart. I will not be focusing a lot on the post-transplant vaccines, but just know that if you are an allogeneic or autologous stem cell transplant recipient or candidate, there are a lot of other vaccines that will be recommended in the months to years following transplantation. These in the schedule are listed very clearly on the National Comprehensive Cancer Network website, and different centers have different protocols, but in general, this is an example of a schedule. And so this is much more comprehensive and complicated than other solid tumor or chemotherapy recipients. And then just wanted to mention the difference between live vaccines and inactivated vaccines and talk to you about which vaccines would be considered live vaccines. So live vaccines mean that the vaccines contain a replicating component of the virus that is present. So they are basically attenuated where the virulence factor or the thing that causes symptoms or the virus to be disease causing has been taken out of their code, but they are still able to replicate. And so in someone that has an abnormal immune system, they're not able to cause disease, but they're not recommended to be given in patients who are immunocompromised, which would include patients that are actively receiving chemotherapy, that are on steroids, or in some patients that have, history of lymphomas and have received more chronic acting chemotherapy agents that might cause prolonged immunocompromising conditions. So if you think you may be a candidate to receive one of these live vaccines, I think it's a good idea to discuss with your doctor before receiving them. Some of these are given for specific indications like travel. And so I think it's always a good idea to undergo a travel consult with an infectious diseases physician if you're a cancer survivor or especially a bone marrow transplant recipient, because they will be able to discuss the risks and benefits of receiving these vaccines with you. And so the first vaccine type we're going to talk about is Streptococcus pneumonia. So this vaccine has actually been around for quite a while, but the recommendations have been updated. So Streptococcus pneumonia or pneumococcus is the most common cause of bacterial pneumonia and bacterial meningitis among adults. And the vaccine schedule can actually look fairly complicated in cancer survivors or patients receiving chemotherapy or in patients with other immunocompromising conditions like transplant recipients. There is a recommendation to receive a two-part vaccine. And so patients that are younger than age 65 will first receive what's called the pneumococcal 13-valent vaccine, or the trade name is called Prevnar. And this is a protein-based vaccine that has protection against 13 strains of the pneumococcal bacteria. And so it causes or elicits a more strong protective immunity, but only covers against 13 strains of the bacteria. Followed by the vaccine that's been around for a longer period of time, the 23-valent vaccine or Pneumovax, by at least 8 weeks later. And they receive that, again, 8 weeks later. It protects against 23 strains of the pneumococcal bacteria, but it's a polysaccharide-based vaccine, so it doesn't have as strong of an immune response as the Prevnar vaccine does. So it is then recommended that they receive an additional vaccine after 5 years and another vaccine after age 65, at least 5 years after their latest 23-valent vaccine. This schedule is a little complicated. And so again, I always recommend that people go to the CDC website to refer to their specific indication to refresh their memory. But it is very clearly laid out in this chart and at the CDC website. Shingles is the viral reactivation of the chickenpox virus. So the varicella zoster virus was usually acquired in childhood. Now there is actually a vaccine against chickenpox, or the primary varicella infection. And so people that were born after the early 1980s often will not have acquired the primary chickenpox virus, and so therefore won't be at risk for developing reactivation of the shingles vaccine. But for those that did have chickenpox as a child, it's a member of the herpes virus family. And what's unique about those viruses is that once you acquire them, they actually develop a latent phase or a quiet phase where they are inactive in the body, and they can activate during periods of either immunosuppression, like during chemotherapy, or as we get older. And so shingles actually becomes a much higher risk infection as people age. And so here's a chart here that demonstrates the increasing incidence of varicella as by decade. And then the other complication that can occur after shingles occurs is something called post-herpetic neuralgia, which is basically a pain syndrome where even after the skin eruption heals, there can be pain along that nerve line that can last for months afterwards. There is a new shingles vaccine that was developed a couple years ago that is no longer a live vaccine. The Zostavax vaccine was a live vaccine, and so we weren't able to use it previously in cancer patients or those receiving active chemotherapy. But the Shingrix vaccine is now a non-live vaccine. It's an adjuvated vaccine, which means it has an immune boosting property to cause a better immune response. And so it offers a better immune protection than the old formulation of the Zostavax. And so it reduces the risk of shingles by over 90%, and it also drastically reduces the risk of that post-herpetic neuralgia, even if people do get shingles after the receiving the Shingrix vaccine. It's recommended in patients age 50 and above, and it's a 2-dose vaccine that's given 2 to 6 months after the initial vaccine. If you miss that 6-month window, you don't have to restart the series over. You just go ahead and get that second vaccine whenever you're able to. Another vaccine that is also very important that sometimes falls off of people's radar is the tetanus, diphtheria, and pertussis vaccine, or TD. The pertussis component is the Tdap, or acellular pertussis. It is recommended that you get the Tdap formulation at least once in your adult life. This is different than the DTaP vaccine that you get as a child. You need a booster immunity once in your adulthood to protect you against pertussis, which is the whooping cough infection. It is okay to get Tdap every time you get the tetanus booster, but the TD shot basically protects you against tetanus, which is that bacteria that can be introduced if you step on a rusty nail. And then diphtheria is that bacteria infection that can cause the plaque and epiglottitis in your mouth and used to cause very significant infections, throat infections. You will also need to get a tetanus booster if you do have a puncture wound, especially if you step on a nail. If it's been more than 5 years since you've received your last tetanus shot, and especially if you've had less than 3 doses of the tetanus vaccine in your lifetime. The HPV vaccine is another great vaccine. It's the only vaccine that can protect or prevent cancer. So the human papillomavirus is the viral infection that causes warts. And there's many different strains of the HPV or human papillomavirus. They can cause plantar warts, the warts on the hands, warts in your nose or mouth. But there are certain strains that can be associated with development of squamous cell carcinoma that can cause cancers of the cervix, vulva, vagina, anus, penis, head, neck, throat, and mouth. And so this is the one vaccine that actually can prevent cancer and is proven to prevent cancer. It is now recommended in all females and males starting at age 9 to 12. And it is standardly recommended that you do catch-up vaccines until age 26. You do 2-dose series if the series is started by age 15. If it started after age 15, it's a 3-dose series. And then it just got approval to be extended in the US through age 45, but there's some delay in whether all insurances will cover it through age 45. So it is something to kind of weigh risks and benefits and look into whether insurance will cover. In considering who should be getting this vaccine, patients who, so HPV is these strains that cause cancers are often sexually transmitted or transmitted via oral secretions. And so patients who have had few sexual partners early in life or that are expected to have new partners and have not had a history of HPV infection would be the highest risk in the candidates most likely to benefit from the HPV vaccine. And then also certain healthcare workers that are likely to come into contact with patients who could be infected with HPV, especially doing procedures on patients who have cancerous or precancerous lesions or other warts. And so this would be a discussion to have with your individual healthcare team. Influenza vaccine, very, very important, definitely recommended to get yearly. The peak influenza months typically vary year to year, but influenza often begins to pop up around October, November. Peak incidents tend to be December, January, February, and then start to wane into March. The full effect of the influenza vaccine starts to take effect about 2 weeks after the immunization. And so, I typically recommend in patients that they start to get vaccinated either late September going into early October. So then they're protected until late October. The effects or the full effects of immunity from the flu vaccine start to wane after about 3 to 4 months. And so you don't want to get vaccinated too early to kind of miss the full benefit of the flu vaccine as you get into February and March. And so timing is important, but you don't want to wait too long either and get the flu vaccine as it starts to circulate in the community. We might start to see earlier flu circulation. We don't really know what the year after COVID is going to bring since we didn't have too much of a flu season this year. And so we'll kind of have to wait and see what happens. But basically, flu is the respiratory illness that causes acute onset of fevers, muscle aches, extreme tiredness, often acute onset of respiratory symptoms, cough, aches, pains. And then the formulations of the flu vaccine typically would recommend that cancer patients and survivors get the inactivated vaccines. There is a live vaccine that is a nasal mist. It was taken off the recommended list for a couple years ago. It's now approved, but it's not very commonly available. So if you're used to taking injections, which many of you are, these are usually the more commonly available vaccines. Right now, most commonly the quadrivalent, which protects against 4 different flu strains, 2 types of influenza A and 2 types of influenza B. Most commonly available is the standard dose vaccine, but there is a high dose vaccine that gives kind of a higher dose of the flu antigen that's approved for ages 65 and greater. There are some centers that use high dose vaccine in transplant recipients and other high-risk cancer patients. There's also an adjuvated vaccine that has a protein to stimulate more intense immune response that's approved in age 65 and greater too. And then finally, the COVID vaccine. So these 3 are currently under emergency use authorization in the US. There's 2 mRNA vaccines, the Pfizer, which is approved or authorized for use in ages 12 years and older. It's a 2-dose series given 21 days apart. And then the Moderna vaccine, which is authorized for use in ages 18 and older, 2 doses given 28 days apart. The adenovirus vector vaccine, which is the Janssen vaccine, also known as the Johnson & Johnson which is authorized in 18 and older. It's a single dose vaccine. It is basically recommended to be given in all patients. It is also, there are some guidance documents from the NCCN in terms of timing in patients that are actively receiving cancer therapy. So patients that have just completed transplant therapy, there is a recommendation to wait at least 3 months due to inability to mount an appropriate immune response after that early phase post-transplant, and then to not get it, just the day before surgery so that you don't have a fever that is confused with a fever during surgery. There's a lot of things yet we don't know about vaccines in immunocompromised or cancer patients. We don't know how well the COVID vaccine protects immunocompromised patients as compared to the normal population that was studied. We don't know how long that immunity lasts for. We also don't know, there are tests that can test antibodies post-vaccine, but we don't really know what they mean and how to interpret them. We think we probably do need booster vaccines at some point, but we don't know when, and we don't know what combination or what cocktail is the best yet. And we don't know which vaccine is the best for each person or circumstance. And so there's a lot more data that we need before we can make recommendations on an individual level. But right now, it's just very important that everyone that is a candidate to get vaccinated does. And so people that aren't candidates are those that have had a history of an allergic reaction to a vaccine or component, and that's basically the main contraindication. The side effects of these vaccines, the common ones are local reactions, so pain, swelling, redness at the arm, the site of the injection. There is also reports of lymph node swelling in the armpits at that side of the arm. And so there are recommendations to delay mammograms, especially if you have a history of abnormal mammograms until, cancer screening for breast cancer, if you've had COVID vaccines. Other common side effects are fevers, headaches, fatigue. And then uncommon or very rare side effects include anaphylaxis or allergic reactions, especially with the mRNA vaccines. And then also blood clots and low platelets with the adenovirus vector vaccine, the Johnson & Johnson vaccine. But overall, those are very, very rare. And so the risk of these happening are much lower than the benefit that we know is present with the vaccines. And so we definitely encourage cancer patients, their household contacts, and all of their communities to get vaccinated to protect them and themselves against COVID. Thank you so much for your attention, and I look forward to your questions.